Hello, everyone, and welcome to the first online seminar from the Public Health Emergency Preparedness and Response Ethics Network. We're delighted to have so many people online today. As you'll know from the poster, from the advertisements, we've got an hour worth of discussion, and the focus of our discussion today is going to be on why should ethics be front and center to the response to COVID-19, and to what extent is that the case. Before I start introducing our speakers, I'm going to ask Catherine Littler, who's the co-lead of Global Health Ethics and Governance at World Health Organization, to say something about the network. Catherine, over to you.
Great, thanks, Mike. I'd also like to extend my warm welcome to everyone on behalf of the newly established, hard to say network, Public Health Emergency Preparedness and Response Ethics Network, otherwise known as PHEPREN. This is a network that we established in January this year. We've been working on it since post-Ebola. We were planning to pilot it over the next 6 to 12 months, but clearly because of COVID, we've got it up and running now. It's a network or a community. We're aiming to create a global community of bioethicists, which will embed ethics at the heart of decision-making in epidemics going forward, both thinking about it in terms of preparedness issues, research and response. We aim to do this over the coming years, first and foremost at the moment, by supporting and coordinating real-time contextual ethics advice, by building fair collaborative partnerships across the globe. This is a truly global endeavor. We want to build local, but also global ethics capacity. We want to be a source of knowledge sharing, hence this online seminar, and resources for the global research and health communities. And we're going to start doing that by the establishment of the Epidemic Ethics website. So I ask you all to take a look at that at the end and not during this seminar. We have already managed to get over 320 resources on COVID and ethics alone. So there's a lot being published. I think we've got a good chunk of it, but I suspect there's a few more out there. And that's anything from statements to webinars to guidance. This is, as Mike said, the first in a series of online seminars that we plan to hold. We're going to have them every fortnight. I'm going to explain the word fortnight because I know people in North America don't use it. Every 2 weeks. So that's the aim at the moment. We'll also intersperse it with other ones. We're looking to do a diversity of topics, everything from fair access to vaccines, to ethics of transitioning out of restrictive measures, to looking at issues of inequality and how COVID's affecting different populations in different parts of the globe. My final comment is really that the success of this new network is down to the bioethics community. So please do join, please do get involved. And for those of you who are on that aren't part of the bioethics community, welcome, and please let us know what kind of information that you would like from us. And on that note, I'm going to hand back to Mike. Thanks.
So first of all, before we start, just important to let everyone know that this seminar is being recorded. And the other thing I suppose is to say is that each of our speakers are going to speak for 10 minutes, but we're also interested in knowing, putting questions to them. So do send us your questions if you think of them through this. And this is really very much a global meeting, people from more or less every time zone around the world, and it's great to have you all with us. So without further ado, I'm going to introduce the first of our speakers, who's going to speak on the topic of why should ethics be front and center to the response to COVID-19. And that's Professor Ross Upshur from the Dalai Lama School of Public Health in Toronto. All of the colleagues on this seminar today are esteemed contributors to global health bioethics. I won't give long introductions because that would take too much time, but delighted to have you all here. Ross.
Thank you, Michael. Good morning, good afternoon, good evening, everyone. It's a real pleasure and privilege to be the inaugural speaker of this webinar series. And I do hope that you and your loved ones are safe and well in these extraordinary times. So the question is, should ethics be front and center? I think the question's already been answered because ethics is front and center in this epidemic. In fact, I'm going to argue that there's kind of a pandemic playbook that, whether people appreciate it or not, indicates that our response to epidemics is fundamentally and built upon ethics. So what's the pandemic playbook? And this kind of draws upon 20 years of research since SARS that I've been involved in, and actually prior to SARS, on ethics in infectious diseases. So if you think of the origins of the SARS-CoV-2 outbreak in Wuhan, what was the first thing that we heard? There's a mysterious new virus, and very shortly thereafter, there was a surge on the capacity of healthcare institutions in Wuhan, indicating that one of the first issues that arose was, oh, there's a need to think about resource allocation and how we're going to manage this surge capacity. Secondly, it was a completely unknown virus. So immediately research was contemplated and started very quickly, indicating that research ethics are going to come into play. Thirdly, we saw, unfortunately and tragically, healthcare providers become sick and pass away, raising questions of duty to care and the limits of duty to care. Finally, stringent public health measures were put in place, raising questions about the legitimacy and justification of these sorts of measures and bringing public health ethics into play. And finally, when we started to see it spread, we had issues with respect to global governance and global health ethics, and issues around public health emergencies of international concern, how we have global collaboration to provide countermeasures. And I would say that this falls in line with how things have gone with other outbreaks. The difference for this, so if we look at SARS, MERS, the 2 Ebola outbreaks, Zika, H1N1 pan flu. So the difference is that this is a true pandemic. It affects all people in the world. And this means that people, it's interesting. I think everyone now who's been affected has become an ethicist, and I've never heard so many people discussing ethical issues. This isn't right, this isn't fair. And then so everybody has their ethical intuitions being twigged. We also realize that there's some very important issues in infectious disease ethics that become surfaced in a large magnitude. So many people who've worked in infectious disease ethics say one of the distinguishing factors is that you become a victim and a vector simultaneously. And because we all have vulnerability, because there is no pre-existing immunity, so we all have a chance of becoming either infected, and by being infected, we become a vector that will give that transmit that disease on. So there's ethical issues at the individual level about the appropriate conduct, about how you behave to your friends and family, about what your obligations are to your community and to society, and what your obligations are more broadly to global communities. So everyone's an ethicist, just like everyone can sing, but not everybody's a Pavarotti. So I think the ethics community plays a particularly special role here in helping move the discourse away from sort of blunt assertion of this isn't right, this isn't fair, to starting to give some reasoned giving accounts. Now, most people have resources that they will go to, and in a broad part of the world, many people will turn to their faith traditions for guidance on the appropriate conduct. And we saw from research that we did in SARS that faith communities can actually be great allies for public health. And we've seen that and witnessed that recently, for example, with the Christian faith during Easter, with Judaism during Passover, and with advice that's been offered to the Islamic community for Ramadan, that there is a role in which faith communities can actually provide ethical guidance, I would say, during pandemics. Some people will turn to friends and families and trusted elders and community leaders for guidance. And there might actually be some people out there who might turn to ethical theories. So I know that there's many consequentialists out there, virtue theorists, deontologists, rights scholars, and as we've witnessed in the past few weeks, no shortage of libertarians in North America looking for justifications for reasons for doing what they want to do. So when I sat this morning before coming in and thought to myself, who would be the ethics guidance that I would turn to? Did I want to bring John Stuart Mill? Did I want to bring Immanuel Kant? But I actually brought the Nicomachean Ethics from Aristotle, because the Greeks actually understood the critical interdependence of politics and ethics, the importance of civic virtues, the idea of excellences and various other ways of conduct that can actually serve communities. So the important thing to know here is I think it's a learning moment for us all to really emphasize the importance and urgency of ethics, because it's not the case that everybody's going to agree on principles, but we can actually set up processes for informed, respectful discourse. The important thing about pandemics is their complexity. They're complex at the ethical level because it goes from the individual through professional, through the public health up to global health level. But we also, as we know, need to understand how to think and act under conditions of uncertainty and integrate varieties of different science. Everybody now has also become an armchair epidemiologist, understanding models. Everybody's becoming an armchair immunologist as we think about what it means to have serological tests. So on the one side, as horrifying as this is a huge opportunity for us all to become better educated, to think through the distinction between science and science fiction, and between ethics and reflection as a reasoned, giving, respectful discourse, or blunt assertion of one's preference. And then I'll stop there and let somebody else join in. Thank you for this opportunity. Very much appreciated.
Thank you very much. Thanks very much, Russ. It's really so much to think about there, and I've got lots of questions I'd like to ask, but hopefully other people out there will as well. So let's just move on now to our next speaker. One of the great things about this online working is you get to see the kind of environments that people live and work in. So we've just seen Russ's office there, and now we're about to see Professor Emily Chan's environment. So Professor Emily Chan was a colleague of mine on the Nuffield Working Party on the Ethics of Global Health Emergencies recently, and she's Professor and Associate Dean at the Faculty of Medicine at the Chinese University of Hong Kong. So Emily, over to you.
Hello, everyone. I'm glad to have the chance to share with you some stories and perspective from our side of the world. I'm in Hong Kong right now in China. And I think together with the team, this discussion, I think it's very clear that there are many issues surrounding ethics around global health emergencies. And as Ross highly points out, there are the theoretical side of the discussion. But I just want to point out a few important things which is happening in the front line or in places where research may be needed, but actions are needed. I think one of the challenge with global health emergencies is that there's of no doubt that with a new condition like COVID-19, there would need science. But the problem is how research is being done could be problematic and could be filled with multiple challenges. People argue that there are challenges in emergencies for ethical principles, but I will argue that it's not the principle that is being challenged, it's the process, how research should be done. Because in emergencies, time it's very crucial. And the research findings or decision made to support the community would mean life and death. And there are a few questions I want to put it in this seminar for, I guess, discussion or even future discussion for colleagues to consider. The one is the whole concept of the power and influence again. Because one of the key problems with our decision made during an emergency for a community or a pandemic for the global community is whose voice is being heard. We would assume that the research, the action that was being done is actually for the sake of the patients or the affected population. But if we actually look carefully at the research being invested, they're looking, of course, at the virus, looking at the genome sequence and all those good things. But the problem is, how are those results being applied to the field, applied to the user is an issue. And the challenge is who is representing the patients. There are many ongoing efforts of treatment, of social policies, of isolation, of quarantine, but there's rarely of their voice being heard, okay? Whether the policies are affecting the community, how about the ethics of placing an underage patient in isolation without their parents. Okay, those are some examples of what's going on, I guess, in many parts of the world. The second important highlight I want to point out is that I am in support of science, no doubt. But there's also the issue whether the current, in the name of science, people were doing a lot of research, but whether the research study design is relevant for the appropriate findings. Because of course, a lot of global comparisons are being done by online, but whether the online mechanism, for example, as research design, may be able to reach the audience or the participants or the stakeholders is another issue. Like in Asia, there are many research already highlight that the vulnerable groups are the ones who are not going online. They may watch TV, they may listen to radio, but they still may not be as online as they should be. And if you want to understand what's happened to them, perhaps we cannot extrapolate. You should actually outreach to them. But whether our research now being done is managing to assess them is another very important point to think about. The third important item, which is not only for COVID-19, is for other global health emergencies, is the idea of a meaningful consent. Again, for research or for work or policies, it is important to understand it's good to study them, but whether the consent was given or whether there's an opt-out process for people to make a choice, at least the respect of that opt-out process is very much a gap right now going on in the world. And of course, the other important thing is who are the duty bearers? We can naturally assume that it may be the researchers, the policymakers, but perhaps donor has a role. Because many of the times it's the donor, because people are concerned with the major future donation and power, they will actually listen to. But many of the times, even for donor with all the good intentions, after they donate the resources for research or for whatever programs, they may not take the responsibility of follow-up to see whether that money was used the right way. And as a result, the intended research may not translate to the right way or translate to the agreed or intended community. And last but not least, it's also important to think about, all the information that was collected for the current COVID-19. Again, pandemic, I hope is not going to happen for many times. We already have a hard, long battle in Ebola for Africa. And this time is an opportunity to learn from this global situation. But how much of the current data or in the name of policy making is going to synthesize to meaningful future? The frustration, because I was also working alongside with my colleagues from the social science community, even I'm a clinician, is that we are trying to look for the evidence to support decision-making in policies. But the challenge is that when we go into the literature, even though a lot of researchers were trying to, in the name of research, collect a lot of data from previous research, but only a few was managed to translate further to support the community response. And what are these, what may be a good framework that we may use or develop because of this COVID-19 for future epidemic or pandemic is actually very worthwhile to think about. It's ethics. It's definitely responsibility for our generation of researchers or people interested for responsible policy making to ensure what is now going on. At least we can minimally synthesize the right response or the right policy or program for the future epidemic. So I just want to pose a few questions, and Mike, back to you. Thank you for the time.
Thank you very much, Emily. And that last theme, particularly about how we can make sure that we learn for the future and we're better prepared next time there's an epidemic or a pandemic, is a theme that resonates with the people who are asking questions, and it came up in Ross's talk earlier. One of the things that's striking about this current epidemic is how little we learned from previous experiences, and we don't want the same thing to happen again. So we'll certainly come back to that question at the end. Thanks very much, Emily. So so now I'll hand over to our third speaker. I don't. Are you unmuted? Yeah, it looks like you are, Jerome. So this is Professor Jerome Singh, who's Head of Ethics and Law at the Center for AIDS Program of Research in South Africa, CAPRISA. So over to you, Jerome.
Thanks so much. And thanks for Catherine for introducing us and for actually bringing the seminar together. I thought what I wanted to do is to maybe emphasize or raise issues from a particularly interesting perspective, an important perspective, and that's the low and middle income country perspective. And I think that in a setting that I'm living in, for example, which is South Africa, which is often described as having 1 foot in the developed world and 1 foot in the developing world, we're beginning to see very, very heartfelt situations right now with our lockdown. And I think this is reflected throughout Africa. So I think maybe to start off, it's important to maybe emphasize that usually Africa is one of the first continents to get hit by major pandemics, especially Ebola being one of the major ones that's been recent. But this time around, Africa has been relatively unscathed and has been hit last. But what figures are showing is in the last week or so, the number of cases has been rising quite rapidly. And new projections are showing that over 300,000 people at minimum could die. And I think what we just need to remember is that with the cases in Africa, while the figures seem to be quite low, it's actually masking what the real situation on the ground is. The lack of testing and surveillance in most countries because of a lack of testing kits and of course surveillance infrastructure is really hampering our figures in terms of knowing how bad the epidemic is spreading throughout Africa. I think it's important just to note that while Africa does seem to have low figures, experts are in fact saying that the numbers are considerably higher. But I think having said that, what I wanted to just maybe speak about is, and for me, what I want to focus on in particular, not so much the research issues or some of the issues that involve philosophical underpinnings, but I wanted to maybe focus on one principle in particular, and that's the principle of reciprocity. I think the important thing in the African context is that many African countries have instituted lockdowns or curfews, and that's had a devastating impact on African countries and especially on poorer communities in those settings. At this point in time, most of Africa work on part of the informal economy. Most people don't have formal jobs. You may find people are hawkers, they're informal traders. And with the lockdown, you're finding lots and lots of people are confined to their homes. They're unable to actually earn an income. And because most of Africa is quite poor, you'll find countries haven't actually put in place any sort of support system to assist very poor and vulnerable communities. So what we have happening throughout Africa, including in parts of South Africa as well, is literally tens of thousands of people unable to earn an income and beginning to literally face starvation. And I think this is actually a very, very tragic situation that's not making too much of headline news, mainly because, right now, of course, most of the news media is focused on the epidemic in North America, especially the US, and of course in Europe, and in particular, what's happening in Italy, Spain, and the UK and France. But I think, a continent like Africa and maybe many other low and middle income settings elsewhere in the world, like in Asia, a lot of the issues that are happening on the ground right now is millions of people facing poverty, and poverty being made worse by lockdown measures or containment measures. So I think when a state actually puts in place measures in the interest of public health, it has to take into account how this will impact on poorer people in those settings. So I think, important to also mention as well from a developing world context is that millions of people in low and middle income countries also live in very dense settlements. Typically, you'll find there are tens of millions of people throughout regions that actually live in shanty towns, or alternatively other forms of habitats, for example, like rural homesteads, where there's quite dense living and quite dense homestead numbers. And I think probably what that raises is that if we're talking about asking people to sanitize and asking people to wash their hands, we have to ask ourselves, first of all, and keep social distancing. The important questions we ask ourselves is, how does that play out in a developing world setting when you have maybe up to 8 to 10 people living in a one-bedroom dwelling, or in a very small space that may not be one bedroom, but at least 2 bedrooms. And you'll find that in that type of setting, it's virtually impossible to keep a distance of 1 to 2 meters. You think about the migrant camps in Syria, other places around the world where you have huge refugee populations, and trying to keep social distancing is close to no, the possibility of doing that. I think we also need to remember that in many places around the world, especially in informal settlements, you'll find that typically people don't have access to water. There may be one communal tap that's quite far away, and you'll typically find that if there are any sort of ablution facilities, these are communal in nature. And very often you'll find that there may be, where in those countries that even have those facilities, there may be a portable toilet, but you'll find that there'll be no facilities to wash your hands. So I think, the important issues is that when we're looking at confronting or dealing with COVID-19 globally, the emphasis of club public health and what authorities have been emphasizing is wash your hands often, keep a social distance, and of course, stay in your homes. But I think we need to remember that those types of rules and those types of constraints provide very, very challenging situations for African countries and other low and middle income countries in Asia and Latin America. So I think when we're looking at how do we actually enforce these types of measures and what are we doing about that, we can't talk about or expect people to follow these measures of social distancing, washing their hands, or as often as they can, when most people in those settings actually don't have access to water, don't have access to sanitation, and in fact are living in quite dense settings. So it brings me back to the principle that I spoke about, which is if we're expecting people, and I'm talking about the vast majority of people in Africa and in Latin America and in Asia who live in more low and middle income countries, you have to take into account what is the state or what are other global health actors like the WHO or even UNICEF and other players. What are they doing to actually ameliorate the plight of the poor and the vulnerable in those settings? Are you providing food packs? Are you providing sanitation? Are you providing water? And if so, how is this being done? Are communities that are expected to stay in their homes and not earn a living, how are they being helped? And how is the state and how are other agencies helping them? I think for me, from an ethics perspective, when you're looking at responding to COVID-19, that for me is the central thing, is that if you're expecting people to stay in their homes and to make a sacrifice for the greater good, we have to ask ourselves, what are we doing for them? For them to actually make the sacrifice for global public health or local public health, the state and other players should be doing something to reciprocate their sacrifice. We don't want to have people be saved from COVID-19 only to starve. So I think for me, those are the important factors that I wanted to raise from a developing world perspective. Thank you.
Great, thanks very much, Jerome, and thanks very much to all of our speakers. We've got, I've got a long, it's great to see the chat here. I've got a long list of questions, so I'll try my best to manage those. But I think the plan is to keep the questions afterwards, so hopefully we can do some more work around those if people have the opportunity to give some answers. But I suppose one of the things that is apparent in the current outbreak from an ethics point of view is the speed with which research plans, so developments around vaccines, for example, the speed and the pressure to do these things very quickly. And so on the one hand, there's a question of speed to do things we're kind of familiar with, developing vaccines. And on the other hand, there are a number of novel research methodologies, or novel in this kind of context, for example, the use of challenge studies. And one of the questions is, given this background of speed and also innovation, to what extent do you think that ethics, research ethics, has the ability to keep up and can make a useful contribution? So if any of you would like to, we could go around, but I don't know who wants to respond to that first. Ross, maybe?
Thanks, Michael.
Yeah.
I think the ethics community is prepared. So we went through a lot of this during Ebola. So if you think of Ebola as a kind of archetypal experience of a serious pandemic with high mortality in a low and middle income setting. In 2014, when the public health emergency of international concern was declared, there was kind of therapeutic nihilism and almost, pessimism. There were no vaccines, no drugs. WHO convened a group to say, should we fast track research into unregistered agents? We said yes. And 5 years later, we have a registered vaccine and 2 monoclonal antibodies that have basically reversed the mortality. Through that time, we had several meetings where we talked about methodology, because there were controversies about placebo-controlled trials, about different randomized control trial methodologies, about whether you can even have adaptive trials. So I think the architecture of study design has changed quite quickly, and I think the ethics community has kept pace. I think that, the Global Forum for Bioethics and Research had a whole session on novel trial designs in global health research. That being said, I think there is still a global lack of capacity, and we really need to build capacity in research ethics oversight globally, so that these kinds of challenging new designs can be understood, their strengths and weaknesses, they can get appropriate ethics oversight. And I know also there's an independent process that's looking very carefully at human challenge studies. So I've actually been quite proud of the ethics community. To be honest, when we showed up at the R&D Blueprint meeting in Geneva with the ethics working group, our house was more in order than other groups, so to speak, because of all of the work that we had done basically from SARS through pandemic preparedness through Ebola. Is it perfect? No. But at least there's guidance there. I still have some questions about how much we've learned, but I think actually the ethics infrastructure is there to actually safely and expertly evaluate. I mean, in the conceptual side, it's on the ground building capacity that the work needs to be done.
Does anyone else want to contribute to that? Or shall I move on to the next question? No? Okay. Jerome, maybe this is one for you to think about, but hopefully everyone has a view. Several of the comments that I've got in front of me relate to the fact that this is a global problem, which is only really going to be solved through, if it can be seen as a global problem requiring shared action, a collective action problem. But what we're actually seeing in practice is countries looking after themselves, and very national level, or perhaps even to some extent regional level, but certainly national level focus on these things. So that raises a number of questions. One question is, can anything be done to help countries to work together? But more explicitly, as an ethical question, and to what extent, if they do, high-income countries have obligations to low-income settings, for example, the kinds of settings you described, Jerome, in yours. Do you want to say something about that, about what you think the obligations of high-income countries are at the moment?
Sure. I'll maybe say something about that and also comment on what are some of the practical issues that I think high-income countries can assist with. I think, right now, most of the high-income countries are very preoccupied with their own domestic pandemic issues, and understandably so. But I think, what is happening is that a lot of African countries are facing dire shortages of personal protective equipment, ventilators. So just to give you some idea, and for those of you who may not be aware, you'll find that, it's estimated that at least 10 African countries don't even have a single ventilator. Others have less than 5 for the entire country. And you'll find that when those countries are not trying to procure those equipment, it's virtually impossible to get them because, of course, you've got the affluent countries also looking for ventilators as well. And at the end of the day, you'll find that when it comes to the totem pole, African countries and poor countries in Latin America and in Asia at the bottom of the totem pole, they simply cannot compete. They don't have the firepower to compete with the mass purchases of the US or mass purchases of Europe. And when you're finding countries like the US outbidding and basically almost, in a sense, hijacking supplies going for countries like Germany, you can imagine that if Germany is getting shortchanged by the US, African countries stand very little chance about, in terms of getting these things. So I think in terms of where supplies could go and what in the developed countries, affluent countries could do, is it would be great if capacity could be ramped up, not just for domestic production, but if a small percentage could in fact be reserved for poor settings in low and middle income countries, and in particular the least developed countries of the world, which actually have very, very little resource. And my advice is that regional bodies, like for example the African Union,
I don't think you're on mute.
No. The only thing, and we're about to finish in 30 seconds, is this is, as I said, the first. We will take the questions, we'll put it up on the website, and we will have more in this session. So please let us know what other topics you would like to have and what you would like this network to focus on going forward. But thank you all for your participation, and thank you, Mike, for chairing, and to our speakers.